So I'm going to be discussing anticoagulation management with ECMO. First slide, just want to discuss hemostasis disruption. So as soon as you expose a patient's blood to a foreign surface, you immediately stimulate inflammation and coagulation, which then leads to a prothrombotic state. The two most common complications with ECMO are bleeding and thrombosis. Our goal needs to be to prevent thrombosis in the patient and in the ECMO system while balancing and preventing a lethal or catastrophic bleeding event. So when you think about, and we talk about patient selection, of course, these are all patients that typically go on. You're in ARDS, multi-system organ failure, raging sepsis. That's the ones that we're already putting on. So they've already spent 24, 48, 72 hours. All those inflammatory mediators already released, all of the clotting cascade already affected, and makes it very difficult to manage them. And then your surgical patients, like your trauma patients, trauma surgeons are hesitant to use it because they don't want all the bleeding issues. And same thing, you've had an acute traumatic event, patients go into SIRS, big inflammatory response. And you talk to those guys and they're like, absolutely not. They're, ECMO does nothing but make patients bleed. And so you have to kind of consider those patients beforehand and what they look like before they actually went on. Again, you have to find the sweet spot of the desired dose of appropriate anticoagulation to maintain a circuit patency by preventing thrombus formation while minimizing the risk of bleeding in your patient. So it is a balancing act, both, between nursing and perfusion. I think, physicians will give you a guideline of where they want a patient to be, but I find it more, if we work together at the bedside, they
absolutely
typically do much better than here's your protocol, shoot for this number, that's it. Sometimes we have to deviate from that, drop down lower than where we're comfortable at times running therapy to continue when you know that a patient's going to be on for a longer period of time.
Correct.
And again, same thing when we start talking about weaning, where, we might have had a lower threshold running them for maintenance. And then we start weaning, we're turning down flow. You've got to go higher so that you don't clot your circuit. And that's kind of one of those things that the physicians, again, they'll give you a protocol, say, meet these numbers, and it's more of a balancing act between
I would agree with that.
Perfusion.
Absolutely, because you can't just go by, the number says 50.
Yeah.
You can't go by that. That's a great number. There's no clotting going on there, but what are the things?
As long as you have good flow.
Yeah. Well, as long as you have good flow,
Exactly.
but it's like what's going on with your patient.
Yeah.
So, we have to look at those windows because, you get it like the one we just put on. No heparin in the beginning, which is most patients these days, right? You're like, why? Well, because they're bleeding. And, do they have a neural bleed? Do they have an abdominal bleed? Or is it just cannulation site? And so I like what she's saying because, yes, the physician, he knows what he wants. But he's not there 24/7 unless you're, doctor. They work with you guys because he is 20. He's there 23 out of 24 hours a day. But having said that, I absolutely agree.
But he also has a very successful ECMO program.
He does. But what I like, though, is that he leaves it in our hands. And I work with her, and he leaves it up to us. We know, because we see these patients all the time, what's in their best interest. And so sometimes we have to not have heparin on board and say, we'd rather not have them have a subdural bleed and change out the ECMO circuit versus, oh, hey, our flows are great, but nothing's going on upstairs.
Right. Yeah, I think Dr. Manny does very well because he will give guidelines, but then he wants input from nursing and perfusion. He really relies on us together to say, what do you think? And he takes the input from us.
He does. I think he's excellent at doing that.
So the most common types of anticoagulants used, heparin is obviously the most popular used one. And then, of course, you see patients with, it's kind of one of those things that I think it's...
Overdiagnosed?
Yes. A lot. So in those cases, we've got bivalirudin or Angiomax and argatroban. So if you have a patient that you suspect HIT, I'm always going to advocate to get hematology in there. I think that that's more than what Palm Critical Care needs to be managing. A lot of them may disagree, but I really think hematology needs to be involved because it is a more difficult balancing act with those patients.
I agree with you on that. I think to take it a step further, I think anybody who's just on ECMO specifically should have your hematology team on. Why would you not have them on board? I mean, we know that your physicians can manage it, but these are the specialists, and how many patients do you have on ECMO out of your entire hospital? It's not a coronary patient or it's not a VAD patient. It's specifically ECMO.
Mm-hmm. And that's going right back to my earlier discussion of we need to have places that have all of these services available, a lot of different disciplines, and not just XYZ community hospital that just wants to put the ECMO in because they could. And now nobody's managing them.
Right. Or mismanaging.
Okay. Maybe they're not managing them as well as they could. We'll say it that way. More positive approach.
So just a little bit about heparin. Again, it's the most commonly used anticoagulant for both children and adults. Potentiates antithrombin 3, resulting in inhibition of thrombin and factor 10A. Levels can be easily monitored and titrated following serial activated PTTs. It has a very short half-life, 60 to 90 minutes in patients with normal kidney function, and can be as long as 3 hours in patients with renal insufficiency. It's the only one that has a reversible agent with protamine, and monitoring methods include ACT, APTT, and antifactor 10A. Pivalaridin is a direct thrombin inhibitor. Can be used for patients who have current or previous history of HIT or heparin resistance. Has been used safely in adults, but I couldn't find any data at all for use in neonates and pediatric patients. But I've always been adult ICU nurse, so I cannot speak to that at all. Monitoring methods include ACT and PTT. Half-life of 25 minutes in patients with normal kidney function and 50 minutes in patients with severe renal impairment. Again, no reversal antidote, so you get a patient that you do start having bleeding issues, becomes a problem, because 25 minutes can seem like a long time when you're emptying the blood bank. Yeah. And it can be used safely in patients with hepatic and renal insufficiencies. Argatroban, another direct thrombin inhibitor, can be used for patients who have current or previous history of HIT or heparin resistance. Again, has been safely used in adults and is the first pediatric labeled safe choice for patients with HIT. Monitoring methods, again, include ACT and PTT, half-life of 45 minutes. Again, the problem with it, no reversal antidote, and has to be dose adjusted for patients with hepatic impairment. So the big thing with the DTIs, they're more expensive than heparin, and that's always
static blood will still clot.
Yeah,
the blood has to be moving.
Yeah,
if it just sits there like a lot of our connectors,
if
our
you're not
sampling
flushing
ports,
if you're not
you have
flushing
to be
hourly
very
or whatever.
diligent with that.
Yeah.
Sorry, we didn't interrupt you.
No, you're good. Then I just wanted to kind of discuss traditional ECMO anticoagulation ranges. Again, activated PTT 1.5 to 2 times the baseline, or a goal of the 50 to 70. ACT 160 to 180 for patients who are bleeding, or 180 to 220 for non-bleeding patients. And then the anti-10A 0.3 to 0.7 international units per mil. Again, those are just ranges. They have to be adjusted specifically for your patient, where you're at in therapy. Are you just going on? Are you day 10 and you're looking at another 5 days? So that's why, I wanted to kind of say in the first slide that it's a balancing act between nursing and perfusion. That's just a guideline, and you really have to look at the big picture.
Can you tell us anything about anti-10A? This
yes, I have another
dosing?
slide on it.
Oh, good, because I don't know a lot of. I don't know a lot about measuring for anti-10A activity. I really know very little, if nothing.
Yeah, so there's therapeutic and prophylactic, which I've got a few slides later. So just ACT, it's an inexpensive point of care, readily available test that reflects time of clot formation via the intrinsic coagulation pathway. For us at our facility, we've got a ACT machine in the ICU, the OR, and the cath lab. So the big thing with that is using your appropriate machine and cuvettes for your area. So obviously you guys in the OR have the high range because going on pump, your patients, you're going to be naturally up over 200. So you have 300.
480 and above is
480. Yeah.
Yeah.
380 and above, I'm happy with.
So the only thing with that is knowing which machine you have, which cuvettes you have, what it's QC'd for, and using the appropriate one. Don't drag that one from the OR back over to the unit for your maintenance and be constantly getting out of range results. Again, can be utilized immediately in the OR, ICU, and the cath lab. Frequently used initially and then serial monitoring and titration. At least at our facility, we switch over to the activated PTT.
Same for us. We use it. We use ACT in the OR, and then initial for initiation is ACT to see if you're moving in the right directions because it's quicker.
Yeah.
And then after that, we convert to PTT.
Yeah, that's same for us when they come. You know, if we've got somebody that couldn't come off pump, coming from the OR, we know that they're going to be high. We'll keep doing ACTs until we're at a point where we're like, okay, ACTs now down where we want it. We want to start our heparin. Now we'll flip over to PTTs because, you know, PTTs turn over fairly quickly in the lab, but it's still 30, 40 minutes on a good day, as long as, you know, somebody got your specimen out of the tube, picked it up, started running it, and it didn't sit down there, hemolyze, and then you're, you know, getting one later. And so the biggest thing with that you have to consider is that results can be altered in patients who are hemodilutional or hypothermic. So again, all your patients coming out of the OR, as much as they try to maintain normothermia, we know they're going to come out, and more times than not, they're going to be hypothermic. So you have to consider that in your first couple ones that you do, balancing what their temp is along with your result.
And that's not to mention if you didn't get hypothermic protocol.
Yeah.
Because you suspect something else, so now you have to keep them cold.
Yeah. Activated PTT is used to measure the clotting factors of the intrinsic and common pathways of the clotting cascade by measuring the time in seconds it takes a clot to form. Typically, the standard for monitoring and titrating anticoagulation therapy for heparin, bivalirudin, and argatroban. It's not a point-of-care test, so again, it's got to be sent down to the lab, and it's usually resulted. We send all of ours, even if they're time studies, we just profile them as stat. They go down in stat bags. They're picked up right away. And then there's kind of some kickback, for lack of better words, and accountability on the lab side of things if something goes down and sits there. And then anti-10A. I'm starting to see this more at my facility. I can't speak for downtown. Do you guys do anti-10As? No. So the antifactor 10A assay is designated to measure plasma heparin, including unfractionated heparin and low molecular weight heparin levels. I'm seeing it more like in the low molecular weight, looking at, are they therapeutic, especially like in our trauma patient population. Not so much in our ECMO patients at this time, but when you look through the research, there are some facilities that are exclusively using this and PTTs to kind of guide their therapy.
I see the factor 10A a lot when I read the European literature.
Yeah.
Because a lot of those guys, and I like what they do, is they use the low molecular weight heparin. And so instead of titrating.
The Lovenox.
Yeah, exactly. You get your dose once or maybe twice sub-Q. And that's enough to get you therapeutic. It gets you not only
for your ECMO patients.
For your ECMO, but they're using it for their general patient population. Because, you know, this study, you want anybody you're using this on, it's going to be a cardiac patient usually, right? And so for us, it's a coronary patient, or it's a bad patient, or it's an ECMO patient. But the ones I see in Europe like this, like I said, they use that low molecular weight because for us, time to be therapeutic is critical, just as important as the other one. Okay, now we're not clotting off, but it took us 72 hours to get there. And so by using this, it's a lot quicker.
But no antidote, even though it's heparin. Protamine doesn't work.
Yeah, but I would much rather deal with the bleeding because you can give things to correct the bleeding, but what do you give to correct the clot other than changing a circuit or trying to, you know, take out a clot out of the lung?
Right, yeah, that's a problem.
So the things personally that I've seen at our facility is some of the drawbacks to it, especially with a low molecular weight. So it's got to be timed, and getting that draw done appropriately with your Lovenox injection within that 30 to 60 minute window post injection. So did your nurse give it on time? Did the lab tech get up there on time? Could you get it resulted accurately is the big problem with it. So there's, different therapeutic ranges. There's therapeutic and prophylactic ranges. So you have to be sure that you're actually looking at and measuring the correct one, and that lab's not resulting out your prophylactic range and you think that you're dosing appropriately. We have a wonderful clinical pharmacist that works in the unit who is much more familiar with this and dosing and literature on that, that really kind of gives us a hand with that. It's typically run, again, in addition to APTT, but it takes longer to result. Effective tool for patients with suspected heparin resistance. Monitoring when initiating therapy. Again, in the OR ICU, a ACT can be utilized immediately as a bedside point of care, but then typically we transition back over to the PTT. Monitor every 2 hours until a target goal is reached, and then you can continue to monitor every 4 to 6 hours depending on your hospital protocol. So I say 2 hours, but you have that patient that's super oozy. It's easy to do every hour, every 30 minutes. We gave some product. Let's see where we're at now.
I completely agree with that. The sooner, the better. And the 2 hours, that's a good number.
Yeah.
Because there's plenty of them you see, right? You give that initial bolus, shoots way up, you're over 200. And then what do? We'll get one in a few hours, and there's no strict protocol. So now you see it trending back down, and you get one, and it's like, it's 90. Great, they're still out of range. Then now you're like, it's 29. Well, it's 1 a.m. So now what do you do? Does it continue to trend down? How do you treat that? So I think that every couple hours is an excellent idea.
Yeah. And that's why we like using the ACT initially, because it's nothing we have to have and, put an order in the computer, send it down to lab. The Hemocron's in the unit. You run it yourself, results right away. And
that one thing I like about the ACT, and it's reliable, but PTT is better. But if you're having a problem, you can run one now, and it'll tell you if you're going in the right direction.
Right.
So you're like, there's a correlation between ACT and PTT. So you're like, if you have 180 and above, your PTT should be here. Yeah. And so if anything, if it was going down, you're trending up, and that'll get you. For me, like in the middle of the night, I'm like, which direction are we going? And it'll give you a little bit of clarity until you get that other result in.
I do have an issue though, I don't know if you experienced this also, but I've run serial ACTs when they're low with the low range ACTs. And I've gotten results everywhere from 130 to 160 to 180 to 140 on the exact same sample. So drew a sample, did it again. And it's not like it sits there and it's degrading because the ACT went up versus down. So, I guess I don't have a lot of confidence in ACTs when we're in the low range. I think you're right. It does tell you, I think, at least give you some idea. If it's 160 or 180, you probably have it's not normal. Right. We know that. But to your point, how much is hemodilution factored into that? How much is being cold factored into that? Cold blood don't clot, but in the ECMO circuit with that big surface area, that can be a problem. I think we do need something more precise, something more that we can depend on. I think although we've been pretty, good at it, we haven't had we've only had circuits clot off when some folks have said, I don't care, turn the heparin off and turn the flow down because it's a VA and it just comes to a stop because it will. And you do that once and you learn and you don't do it again. But I do think we need a better test that can turn over faster, that does do what low range ACT is intended to do, but more reliably. I do feel that way.
I think problem with reliability that I've seen with it is, who's managing the device when it's 3 months, no ECMO patients on. Is somebody actually doing the QCs every month like it's supposed to be done? I think that's more of an issue that I've seen with the Hemocron that device has been sitting there, hadn't been QC'd, or doesn't get QC'd correctly. And that's when I've seen more of a difference in, why did I just get 180 and I ran it again? And now it says, 120. It's the same specimen. I think that's more
done
of an
within
issue.
180 seconds of each other.
Yeah.
And that is a concern for me too. Yes, I agree.
And of course, if at any point you have to stop your anticoagulation for any reason, then of course you always want to go back to your frequent monitoring. Again, every 2 hours or more frequently until you're therapeutic, and then go back and resume every 4 to 6 hours per your hospital protocol. So in community settings where they don't do a lot of ECMO, that's where you get into trouble, where they don't really understand. There's not a lot of that collaboration between nursing and perfusion. And so, where we are, I've seen patients that they want to transfer downtown, and we're meeting that wall. No beds available. We want to decentralize everything. And, and here you are, now you're stuck. So again, I do think that selection of community setting facilities and say, hey, look, these guys do this often. They work with perfusion, they work with nursing, with the critical care team, really know how to manage these patients and kind of prevent that.
Right.
Asking for help is really, I think, even if you aren't going to transfer the patient, if you're stuck with it, just ask for some help.
Yeah.
That's it.
Which I don't understand it. It's not defeat. We're a team,
No, that's what I said that in my previous talk. There's too much inter-facility competitiveness, and we're in the business of helping patients. I don't care who it is. I don't care who the clinician is. I don't care if I despise that person. There's very few people I despise, but even if I did, I'm going to help them. Yeah. Okay. Now, after it's over, did everything we could do, I'm going to go back to, saying how I feel about them. But I'm not, in the moment, we're all in that same business. And I feel like nursing is the same way. Yeah. If a nurse from another hospital called you up and said, hey, we've got this situation. I know you do a lot of this. What would you do in this circumstance? You're going to help them.
Absolutely not a competitive bone in my body about that. Right. I will go to that facility and help them.
Exactly.
If you need me on the phone or if you need me there. It's not about I work for Herman and you work for so-and-so. It's about a patient.
That's
bottom
right.
line.
And I think that's very important for everybody out in the rest of the world to know that clinicians, this is the mentality that we have. I think it's a very important point.
Yeah. I just wanted to throw up some additional lab studies again to monitor. Obviously, careful attention to CBC with trending of your hemoglobin and hematocrit and platelet count, at least daily, if not every 12 hours. Daily CMP to monitor and trend renal and hepatic function. And hopefully there's a CMP or some sort of idea of hepatic function before you ever went on. Your cardiac arrest patient that drops, that goes on, obviously you can't have on, but your sepsis patient, hopefully there was an idea of where we were beforehand. Daily fibrinogen, and plasma-free hemoglobin or LDH if hemolysis is suspected. And again, if coagulopathy is suspected, then you can utilize a rapid TEG to assess platelet function, clot strength, and fibrinolysis. So rather than just guessing at what product do I need to throw at this patient.
Absolutely. We do. I think that is a test that is underutilized. I understand not every hospital has the ability to run one of those, but it will save you money, time, and patient care if you can say exactly where the angle is, what your waveform looks like.
And why not? Why doesn't they're not expensive.
Yeah, they're not expensive at all. They're not.
No. I know part of it is time.
Pound foolish.
But in an ECMO patient or even post-cardiotomy patient, we do that. I know we do that for transplants and VAD patients. Usually if we try to time it right, 30 minutes before coming off bypass, we run labs, we send them. So whenever we're coming off bypass, heme path comes back in there and says, oh, don't put all those cells in there. here you go. Here's some Amicar. Here's this. We can do this.
Mm-hmm.
Yeah,
Good.
especially with the big move towards blood conservation and not using as much product. Hopefully we'll start seeing physicians. And I think the biggest problem, especially where I'm at, is like a lot of them don't even know that we've got the tool available in the lab to utilize it, or they don't know what to do with the results. I had one surgeon where I was like, I'm not asking you, I'm telling you, I'm going to send this. I'm not going to stand here and have this argument with you about, is this bleeding issue, or, because I felt very strongly that the patient needed to go back to the OR. I felt like it was a proline deficiency, and he disagreed. And I said, well, I'm not going to stand here and have this conversation with you. I'm going to send this off, and then we'll discuss it. And I mean, he just flat out told me, he's like, well, I don't know how to interpret that. And I said, well, I have this little book right here, and it gives you directions.
That's what your lab, that's what goes back to that heme tab person. Because there's a big difference between platelet function and platelet count.
Yes.
Yes, absolutely.
So it is really
And when you're
underutilized at this
bleeding,
point. Yeah.
And you're resuscitating with non-coagulation factors.
Yeah.
You're bleeding coagulation factors. So guess what happens?
Yeah.
Your counts go down.
Yeah.
Eventually you do become coagulopathic, but you're never going to fix it if you don't
let them
fix the
continue to
holes.
bleed and use up all those factors and wonder why there's nothing left to clot afterwards.
And then they have a tamponade on top of it now because it's all bled out.
Exactly. Wanted to throw a slide up here, of course, about nursing considerations, minimizing unnecessary blood draws. So a lot of times, depending on what kind of patient, like ARDS patients, when we put them on, and they've got any hint of renal dysfunction, we push early for initiating CRRT with these guys as soon as we put them on. So you'll have nephrology who wants this set of labs every 4 hours. And then you want critical care who wants this every 6. And so as a prudent nurse, that's where I feel like you should say, hey, look, no, do we really need every 4 hours? Let's go 6 with this. And I'm going to time everything all together. Don't just be, okay, this doc told me to do this. Use some common sense with it and kind of cluster your blood draws together.
Yeah, absolutely. Lab sampling hemorrhage is real.
No, really, it's true. Everybody should be treated like a Jehovah's Witness patient or a pediatric patient.
Yeah.
Don't just throw generic things at the patient, hypovolemia or whatever. Be more specific.
Yeah.
Yep, absolutely.
Again, trickle feeding these patients early on to minimize gut irritation and reduce risk for GI bleeding. The critical care guys will look at you when they're like, when we ask about this in rounds, hey, I want to start feeding this patient. Again, what kind of patients are we putting these on? Not healthy patients, already stressed patients. And why let that be a deterrent? Because then here goes your doc saying, oh, look, now they got a GI bleed because we put them on ECMO. I know we shouldn't have put them on. So something as simple as feeding them early on to prevent everything that every potential negative effect that could happen.
Now, is this steak and potatoes? Or?
Absolutely. We are at the Woodlands.
With some beer?
Yes.
That's right.
And again, utilizing PPIs, it sounds simple, but you have somebody that's super sick, you've got 10 drips in the room, they're cannulated, and somehow the simple stuff always gets missed. So that's why I wanted to throw that up there. Again,
what's PPI?
Proton pump inhibitors, Protonix, Pepsid, protect that gut. Collaborate with the physician and the perfusion team to maintain the lowest possible threshold, especially if you foresee the patient's going to require an extended period of time on therapy. Again, that's initiating. And then, of course, when we start talking about weaning and reducing flow, you have to know that balance of, all right, I've got lower flow states. Now I know I need to run a little bit higher.
How old is my circuit?
Yeah.
So now you're 3 weeks in, and it's the same oxygenators when you started, and now I'm trying to run it at 2 liters. You may or may not have a problem. Post-oxygenator gases. It's one thing to say, oh, everything's great, we're weaning down, but now you need to see how well is my device functioning.
Yeah.
So you need to do that in comparison with what you're doing to give them the best benefit.
Don't worry, in our program, we would never have an oxygenator on for 3 weeks. Never going to happen.
Sorry. Maintain platelet count thresholds. So I asked my docs early on, hey, where do we want to be? Just kind of general guideline, greater than 20,000 in non-bleeding patients and upping that to greater than 50,000 in bleeding patients. Again, taking a proactive approach to managing these patients. Don't wait until your platelet count is non-existent and then wonder why there's an issue. And then the other thing that I'll ask for is a H&H threshold. And, at what point do you want me to transfuse? And just getting that ahead of time, having it, I literally write it on the board in my room. So I'm not calling my doc in the middle of the night. And I've got my blood set up and ready to go.
Type and cross. That's a big thing I see. They don't predict that. You're like, they're going to bleed. We drew labs and this is what's going to happen. Can we go ahead and type and cross because we're going to need to transfuse at some point?
Yeah, no, there should never be a reason that a type and cross, and it should not be current and renewed every 3 days on these patients.
Exactly. But how many times do you see that, hey, we need to get 2 units. Oh, well, we need to type in screen and send it to them. And
yeah, absolutely unacceptable. It happens at my facility and somebody.
Especially if you have a issue occur. Yesterday during my presentation, I talked about, circuit design and safety, and when you have ports that are there, and I showed some pictures of an operating room, but it wasn't a surgical mishap. It was an ECMO mishap of fortunately the positive sign, a line come off and blood went everywhere, and it was a big mess. And that patient, that can happen, and now that patient needs to be transfused fairly quickly. But if you don't have them type and crossed, so it's going to be O negative, but why do you want to do that?
Yeah.
And what if you don't have O negative?
or it's going to be whole blood, or
Or it's going to be whole blood, whatever. Right.
Yeah, that's one of those things with experience in running these patients that you get to know, hey, that's one of those no-nos that is not allowed to expire. Always, it seems like a simple thing, but maintaining normothermia in your patient. Whether you have a Foley temp sensing probe or you put a rectal probe in these patients, I think like a lot of times temperature is one of those things that people just don't think about. These aren't patients that you're monitoring every 4 hours and watching fluctuations. No, you're watching them every hour and using your heater cooler. Using your heater cooler to maintain your patient temp. It seems like a very simple thing, but normothermic patients don't bleed as bad as cold patients bleed.
Right. Cold blood don't clot.
Exactly. Questions?
What happened there? Yeah, I have a lot of questions. Actually, Nate Badair. Now, let's stick on this subject because Nate had a question for the previous one too. But on the hemoglobin threshold, I'd like to talk about that a little bit. And my next slides are going to be a little bit interesting with this too. But why are we running hemoglobins of 21 and 24? I mean, is that enough? How do any of us measure DO2?
we do in ours because we have pulmonary groups that come through. They measure everything like that. I can't say it's standardized, every 4 hours we're measuring that oxygen extraction, et cetera. But no, I still think it's done. But for me, experiencing it's with bypass too. I don't like the high crit with our bad patients. They want it on the higher side.
We're not talking bad now.
I know, but I'm saying these are the same patients. So for coagulation reasons, though, and flow for us, I see a better difference. I mean, if you're running your blood gases. And you look and you see your saturation on the monitors, 90 and above, 95 and above, and you get your gas that comes back and your PO2's 150 and above, which is usually greater than that. To me, those are good indicators. That's not always a good indicator of extraction, but then you can run a venous gas. And so if you have those three, I don't see what the big issue is. I like that better flow, better capillary perfusion.
Well, I mean, I think that's but okay.
So what's your minimum?
Why do you say there's better capillary perfusion? What's your crit now? Mine's 48. What's yours?
I don't know. I haven't.
It's over 40.
Yeah.
Yours is probably 40 as well. Females tend to run a little bit lower, but not that much. You're both healthy individuals.
But you're not running it through a device either.
the device isn't what the holes in that device are much bigger than a red blood cell than a capillary.
I know. But
So, I just don't understand. What do we run it at? What do we do? Let me ask you, what do we do at where we do a lot of ECMO together? What's our normal, hematocrit that we're comfortable with?
So 27 to 30. And then after that, you've got to look at your patient. Do they need carrying capacity? Are they still requiring pressor
So
support?
27 to 30. You?
same thing. It depends on the patient, but no, but it's 20. It's on the higher side, but that's still 27. It's 8 hemoglobin.
No, but what do you like?
Oh, I like it. I like running the middle.
27 is 9. And 30
I like
is 10.
it's probably 26, 27.
Okay, well, that's not too bad. Is that what you guys did over your old place?
27 to 30. I mean, we like to put 10 and 30 as a goal, but you kind of work around your individual patient.
I get just real uncomfortable when I see it 21, and I've had people tell me we're not transfusing unless we get down to under 19. And I just think that's too low.
No, I've never had
for
that.
a variety of reasons.
Maybe on bypass, they would say that, but I've never had that with ECMO, ever.
Even on bypass, I think it's too low.
Depends on what you're, I mean, we're doing everything for them,
We have a heart that's being revascularized.
Lungs that are collapsed.
Whether or not.
We're ventilating for them.
Right. Whether or not that revascularization improves, which it should, cardiac function, they're still, even with del nido cardioplegia, they're still experiencing an insult to the heart. And now we come off bypass with a hematocrit of 20 or 21. They're third space, they're full of fluid, they have to be diuresed, and now the heart has to work harder to pump the blood fast enough to get enough O2 out to the tissues. And, I mean, I understand transfusions are troubling on their own merit, but I just really think that is as bad, if not worse.
What about, as soon as you come off bypass, you should have some kind of cell saver blood to give back. And then if you're able to bring them up with that, then you haven't exposed them to a transfusion unnecessarily.
But it depends on your technique that you use. So, I think that for some people who come off bypass with a reservoir full of volume that they can now send to the cell saver, which I think is a bad idea, but you get the red blood cells back, but you've thrown away the platelets, you've thrown away the plasma and the effluent and all the other clotting factors and the COP capacity, because that's, those proteins are very important for that, and it's replaced with saline. So I think third spacing is exacerbated because of that. If you ultrafiltrate on pump and get your level low enough to where you just have enough volume to come off bypass and then flush your circuit, I feel like you manage, at least I do feel that I maximize my hematocrit and concentration of platelets and clotting factors, but they can always add there's enough room for them to add some fluid resuscitation, crystalloid fluid resuscitation or albumin or something like that if necessary. But I feel like heart surgery patients, critically ill patients, ECMO patients, VAD patients, we don't want to give transfusions for nothing, but I do feel that this concept of blood conservation versus sensible transfusion management is an ill-advised concept, because I think that you cannot survive in critical care medicine without the ability to transfuse. That's simple as that.
Well, part of that is knowing your particular patient, taking size into factor. Are you altering your circuit, to try to accommodate for those smaller patients? Are you monitoring your blood volume throughout the case? Maybe you have a ultrafiltration device available immediately. You're anticipating that before you get them fully diluted. Especially with, cardioplegia that's a lot of crystalloid, whether it be del nido or whatever. Are you anticipating that? Are you taking care of that when it's happening so that when you do come off bypass, you are as concentrated as you can be, and then you're not going to lose, all that stuff going over to the cell saver. I think if you have constant management of your hematocrit while you're on pump, you're still going to get probably 1 to 2 units of cell saver afterwards. And sometimes that can be just enough to bring them up to where you want to be, and you're not having to transfuse them.
I think, absolutely. I think it comes down to technique. I do want to say, though, ECMO and cardiopulmonary bypass patients are a little bit different management of patient population. Yes, it's the same concept, but when you're in ICU with ECMO, you can only do so much.
Right.
But when you're in the OR and you're all cardiopulmonary bypass, you have a lot more play and window of what you're doing.
Sure.
Yes, I would agree with that
So,
too.
but temperature is a factor because in ICU, we can only say warm the patient or cool the patient. In the OR, not only do we cool the patient or let them drift, then we give the cold cardioplegia to the heart. So there's literally, you give them that at 6 degrees, 2 degrees centigrade.
There's a lot more protection.
There's a lot more protection strategy there. Now, having said that, a technique that I like to implement when we come off, so depending on your volume, you have to have a certain amount to make it work, but you come off and, you're giving volume, you're looking at CVP, you're talking to anesthesia, you don't want them to squeeze too much and, tear some anastomosis. But providing all those things are okay and bleeding's okay, you're going to say, I bag mine. And so, because timing is a factor in the OR, even when we come off and they're still under anesthesia, so I say, I want to give this blood, we're giving blood, and they want to take out the aortic cannula. They want to start suturing and closing up. So now, instead of sending it to the cell saver, which is acceptable, I ask them, can I bag it up? So yes, it's still anticoagulated blood, so you may have to give a little bit extra protamine. But now I just bagged up 600 and gave them 600 of the patient's whole blood. Not only does it not count as extra volume, so you can say, well, how many cells saver? Because they're trying to count volume loss. Or how much did we transfuse? Oh, no, this is their blood. So you don't even have to count that in there. You're just giving it back to them, but you're allowed anesthesia to do it at their own pace instead of, they can trickle it
And
in.
as the patient needs volume.
Instead of making them squeeze or dilate.
Whole blood heme, essentially, that is theirs. It is autologous, in essence. Are there any questions in the audience? We have a great audience participant here, Eric Brodowski. Eric, come on up here. Yeah, bring your mic. We have a question from the audience. Come on, stand right over here behind me, next to Kimberly and I. Eric Brodowski, it's good to see you. Thanks for coming over this morning. We appreciate you so much.
I got a couple of questions here.
You're talking to your mic.
Sorry.
That's all right.
One question would be,
That's okay.
With the increased survival rate in France, is seeing the on-scene ECMO. Why hasn't the U.S. embraced the on-scene ECMO?
That's a good question.
Oh, absolutely. Well, we regulate a lot more here than the rest of the world, which is a double-edged sword because of that, it's a lot safer for you. And it's a lot more difficult. They make a lot more money here as a physician than they do over there. I personally, I'm not talking down to them, but I don't want an EMT putting ECMO on somebody. I want somebody who's critically skilled and trained, whether it be a cardiologist or surgeon. I want one of those guys to put that in because that's what they know what to do.
Well, wait now. That's a good point, but it's not an EMT putting the cannulas in France. They are physicians who are very trained at cannulating vessels who get on the ambulance and go with the crew. So, no, I don't want somebody who is not trained in vascular, insertion of cannulas, especially when they're massive, if we remember the video. I want somebody who knows what they're doing. But I think he's got a very good point. That is that we are much more regulated here in the United States. There's also a cost issue. Huge. Training. France is a country about this
sheer
big.
Size.
And, France fits into the northeast sector of the United States, the great New England states. And the United States is huge and enormous. And they're only doing it in Paris and only in a few areas. They'll go, but not every patient is going to have that afforded to them. But those patients that do, they're seeing these results. It's going to be studied. Now, with that said, University of Michigan is currently preparing their protocol to do this as a pilot project up there in Ann Arbor. So I think we're going to see it eventually here in the United States.
I just think it's too great of a liability risk.
Well, it's getting the physicians, having enough physicians that are trained to do that.
Yeah, but I mean, you're talking to somebody who's making, and it's not always money, but it is in this situation, you're going to pay somebody $750,000 a year to ride in the back of an ambulance?
Well, they don't. The ambulance is in a particular location. It's in a hospital. Mm-hmm. And then when the call goes out that they have a sudden cardiac event, then they all go to that ambulance.
It's a response team.
It's a response team. They're not just riding around in the back of the ambulance.
No, I get that.
You need to look at this.
No, I read it.
It's really a pretty decent program.
I've seen the videos. I guess what I'm saying is it's such a liability. Here, I mean, you ought to call dispatch and ask them, how many AMEs do you have or suspected AMEs do you have every day in the greater Houston area? 1,000? 1,500? So imagine how many physicians that is just for that right there.
Yeah, but that's an AMI. That's not a sudden cardiac death where they're resuscitating them in the grocery store. There is a big difference.
No,
you come in with an AMI,
what I'm saying is
you've got the door to lab time, the door to, what am I trying to say? Door to balloon time.
Yeah, door to balloon time.
And that's the metric there, and that's shown to be very successful. The golden hour for a soldier that gets injured on the battlefield, same kind of concept. And you can't, you can, but you can't argue with the fact that when you look at patients who have a sudden cardiac event in the cath lab, in the street, who are brought in under resuscitation, the thumper pounded on their chest, and you take that same group of patients and they're put on ECPR in the field and brought in, that those patients have a higher survival rate. That's just facts.
Well, yeah, because you're getting
facts are facts.
You're getting the perfusion, but again, like I'm saying, we know, hey, they're having an episode, but the person next to them says, I think they're having a heart attack. Send the team out there. Now, yeah, you're going to say, well, they're not, so we didn't have to put them on ECMO. It's going to go back to, well, they would have made it. You didn't need to go out there. But now, how are you differentiating in a large populated area the difference between a cardiac episode and not losing consciousness? Not everybody has an EKG on.
No, but I'll tell you this. Yeah. So it is complicated. I think the real reason is liability, if you really want to know how I feel about it.
In the United States, absolutely.
In France, you aren't going to be sued for it if the patient doesn't make it. Because they're socialized medicine and you just can't sue like that. Doesn't happen. But here, they sue for everything. If you saved their life, but they lost their leg, they're going to sue you. And that has actually happened where they saved their life, but lost their leg and people were sued. That's happened right here in Houston. And I know who it happened to. You do too. So it's a very real problem. But I think that what the translation for this is for me here in the United States is more emergency rooms having the ability to do rapid ECPR on a patient that comes in, emergency cardiopulmonary resuscitation or mechanical cardiopulmonary resuscitation. In other words, putting them on ECMO to support their circulatory system until you figure out what to do with them. I think that is much more feasible here in the United States, even in places that don't typically do ECMO, simply to save their life as an emergency department procedure, so that, and have those strategically positioned, and then those patients get transferred to a different place that can do something more with the patient once a decision is made. In other words, it's used as a bridge to decision. Save the patient's life if it's salvageable, and you got it saved, you have them stable. Now evaluate the patient for viability. If they're viable, do something else with them. If they're not, you got to turn it off and let them go.
Yeah, but it needs to be the same thing with a selected number of facilities. That will actually put the correct patients on. I think
you have to be a level 2 trauma center at the very least.
Right.
I don't think if you're not a level 2 trauma center, you should be doing it.
I think you need to have a team of hospitals if you're going to implement this. Because of the logistics alone. So you say, we're going to go to Methodist downtown. That's going to be our trial hospital. That's great. But we all know how emergencies work. So, and legally how they work. You don't go, everybody, you got to go to Methodist. I'm on the north side of Houston. You got to go to Methodist because our EMT guys, physician, whomever putting you on ECMO, got to take you there, or they don't want you. Or you pass 17 hospitals on the way, and legally you're supposed to stop at the closest one to your needs. So I think you'd have to have a team of people, like a team of hospitals.
They're going to have to be strategically positioned around the city just for our sheer geographic size.
Now, one thing that I will say is, if somebody's witnessed CPR somewhere, I do think there's a factor that could be played in there to say we can meet you versus you coming here. CPR in progress coming from where? And well, you know what? We got a team that we can dispatch in the area. We'll come meet you, put them on ECMO. I think that's a good probability of possibly happening for ECMO on the street.
Yeah. Yeah.
Or sporting events. Yeah.
Next question. I think they're all good points. All very good points.
My other question is, what other future trends do you see in the ECMO market?
Future trends in the ECMO market. Well, that's a good question. And I think that we sort of have been beating that one up. And I think for me anyway, I see the future trend being increased use of it because I think it's going to be used sooner. I think we're going to find that using it sooner benefits the patient. So I think utilization will go up, but duration will go down because you won't have as many patients who you can't now get off of ECMO that just stay and languish and consume all of the resources.
Well, and don't you also think that we're going to have, I think the trend will be instead of so many places putting people on ECMO who maybe don't have the experience, don't have the management skills with reimbursement changing, that's going to decrease and we're going to start seeing real ECMO centers. I think that's what's going to happen because the reimbursement for, the success rate is going to be looked at. And just because you can doesn't mean you should, or they're going to allow you to.
Right. In regard, yes, I agree with you 100%. Again, taking it that step farther, I think you're 100% right. Although I think reimbursement, because there was a big change in reimbursement. Everybody, I think, is aware of it. They made draconian cuts in the reimbursement, and I think it's going to be readjusted up. However, and with that said, only 10%, and I learned this from your dad, by the way, only 10% of patients who get ECMO are Medicare recipients because ECMO is a young man's game. It's a woman's game. It's a young person's game. You rarely ever see 85-year-old grandpa getting put on ECMO. It does happen. I know it happens, but it's rare. Usually it's the 56-year-old, 47-year-old, 38-year-old. So I think, yes, I agree with you. I agree with you. I agree with you. And I also feel, as I stated previously, that you're going to see emergency departments, you're going to see that happening. You're going to see, and I think that cost is that reimbursement's going to get up adjusted. They're not going to leave it like that. It was a whole scheme associated with that. I won't belabor the point here, but there was a whole scheme associated with it. I think we all are well aware of who was involved in it, but I'll leave it unsaid.
I personally think reimbursement is going to continue to go down. We're going to see a trend more of.
It can't go down further than it is right now. Currently, it's upside down. If you had a Medicare patient that you put on ECMO that was not centrally cannulated, the hospital will lose so much money that if they even did 4 or 5 ECMOs in a year, legitimately on Medicare patients, they would go bankrupt. It's not going to stay there. It's a ridiculous thing. Of course, we can have this discussion later, and we will when the correction gets made. We'll come back on and we'll discuss that correction. Well, and you have to promise that you're going to be here.
No, I'll be here.
But I'm going to stand. I'm going to take it, whatever it is.
I just think it's going to continue to go down.
Don't get scared.
Don't get scared. The government, you don't ever see them say, you know what, we should pay them more for that. You're just not going to see that.
Well,
but the cuts were ridiculous from 101,000 to 8,500. If you're thumping on the person's chest, 8,500 doesn't even cover the cost of cannulating that patient.
Right.
I mean, so the cost of one ECMO circuit, depending on which one you use, could be $14,000. It's not going to happen. They're
going to put a squeeze on them and say, we need it at a cheaper cost, just like big supply stores.
Yes, but I think it's going to go, I don't think it's going to be any lower than reimbursement for one of the, Archimedean screw pump devices out there. I won't even say their name, which is about $75,000, DRG 215, which is, and their device costs anywhere between $28,000 and $37,000, depending on which one you're using, the 2.5 or the 5.0, and the CP is in the middle. But would be that as it may, the CP has to be put in surgically. It's a little more complicated. And they're finicky too. They're not. And if you have right heart, again, we have right heart, you need an oxygenator. I mean, it just becomes a very complex system. And I think with STS, with the other manufacturers of the ECMO devices involved in this, I don't think they're going to be able to. There's no way the public will eventually get a hold of this if CMS does not negotiate in good faith with STS.
Right.
And they're a powerful organization. I wouldn't mess with STS.
No, I agree with you.
Okay.
But when I say finance and reimbursement, you can't look at it as the government saying we're going to give you $1 for this procedure. All they're going to do is manipulate the technique around that dollar. So what I'm saying now is, okay, you know what? We're going to give you your $50,000. We're going to go to that.
It's going to be probably 80 to 90 is what I believe.
But what I'm saying is now they're going to manipulate other things around it. So we're going to give you 50 if you have perfusion staff.
Yeah.
Oh, but you want to go to the nursing model? We don't reimburse 100% for the nursing model. They can take care of them, but they're not highly as
I
qualified.
think that's wishful thinking for people like you that don't believe that nurse ECMO specialists need to be used. The fact is, there are not enough perfusionists to manage all of the ECMO coming.
No,
now, if
you're
ECMO
right.
goes away, that's a different story. And I love you, but I fundamentally disagree with you on that point. I don't think they're going to say that at all. And I really think that
Something similar.
She agrees
I think there. It may not be that exact point, but I think that is going to be how they manipulate it. They're going to have certain parameters that have to be.
I think it'll be duration. I think it'll be some other factors involved. But I don't think they're going to say who is managing the ECMO patient is going to determine your reimbursement. I just don't believe that.
Well,
And I
it
think
works the
that's-
same way for physicians. They have to round every day to get that dollar, and you can't have if you're ex-physician and you're pulmonary critical care, you have to round on that patient every day to get that full reimbursement.
That's their patient.
This is the hospital's patient.
Yes.
This is this nurse's patient. This is this perfusionist patient. It's going to get back down to the dollar.
Yeah, we'll see. We'll see.
They're gonna
Well,
regulate.
that's another discussion for another day. That's a whole session we're going to do. You have any other questions?
I'm good. Y'all answered
That was
all.
it?
Yes, sir.
Did we answer your questions?
Yeah, I answered them.
Okay, so what are you going to do when you decide what your career path's going to be? What is it?
You know, I'm interested in the medical field, and I'm gonna, look into more jobs, in the medical field and see what interests me the most.
So why isn't your question, is the medical industry a good industry to get into?
Obviously, it's a good industry to be in. See my dad and what he's in, and see what y'all talking about, and it seems like a good industry to be a part of.
So what do you like more? Do you like the clinical support for a particular device like your dad is, and being an expert at that particular therapeutic modality and facilitating and helping physicians with managing their patients? Or do you like what we do, which is more direct patient care
More direct patient care.
and arguing amongst each other about how things are going? Because that's what we do really well. We argue a lot.
Yeah.
And that's what makes this job so much fun.
Yeah.
Is we can argue about things like that. Good. Thank you very much. We appreciate you coming up.
Appreciate it.
Thank you.